Okay, so let's start with the topic. So these are the objectives of my topic. Can you see my slides? Is my audio okay?
Yes po.
Yes
Okay,
po.
thank you. So these are the objectives. First is to understand the different types of anemia, the causes, the symptomatology, the laboratory diagnosis based on RBC alterations and prognosis, to understand and to understand. Also included in that would be the blood transfusion reaction. So let's just review a little bit of the normal development, the normal hematopoiesis. So on the third week, intrauterine life, the most active site of hematopoiesis would be the yolk sac, followed by the liver on the fourth week, and it would be taken over by the bone marrow on the fourth month. So if it is in the yolk sac, we call that there are several stages of normal blood development. This would be what we call the embryonic stage. This is the hepatic, and this is the medullary stage or the bone marrow stage. From birth, the bone marrow throughout the skeleton, um, the bone marrow throughout the skeleton that would be taking over from the liver. There would be minimal hematopoiesis noted in the liver, and from 18 years old and up, the most active bones for hematopoiesis would be in the vertebra, the ribs, the sternum, the skull, the pelvis, the proximal humerus, and femur. So these are the best sites if you would like to take samples for bone marrow aspiration and biopsy. In the adults, 50% of the marrow remains active. So this is what we call this is where they have the yolk sac stage. And then the liver, shortly, together with the liver, is also the spleen becomes also a major source of hematopoiesis. And then from the fourth month onwards, it would be taken over by the bone marrow. So this is just to show you the active sites where the hematopoiesis will be very active at different parts of the skeletal system at different age groups. So usually in the tibia, it goes further down by the time you reach the 20th and the 30th year of life. Likewise in the femur, so the best site, if you have a patient who is older than 30 or 40, so the best sites for bone marrow aspiration and biopsy would be the vertebra, the pelvis, the sternum, the ribs, maybe in the lymph nodes, but it's quite difficult to aspirate from the lymph nodes. So the best site would still be the axial skeleton. So these are the normal hemoglobins. So 95% of adult hemoglobin is composed of two hemoglobin chain, the two alpha chain and two beta chain. And 3% of adults, adult hemoglobin would be composed of your glycosylated hemoglobin, most especially seen in the diabetics. And 2% would be your hemoglobin A2, which is composed of two alpha chain and your two delta chain. And then you also have the fetal hemoglobin or hemoglobin F, which is the major fetal hemoglobin from the 3rd to the 9th month, and it has increased transport of oxygen from the placenta, and it is considered or composed less than 1% of the adult hemoglobin. As you can see, it has a 2 chain, 2 alpha, and 2 gamma chain. And then you also have your embryonic hemoglobins for Gower 1 and 2, which is composed of a 2 zeta and 2 epsilon chain. Gower 2 is composed of 2 chains of alpha and 2 chains of epsilon. Then you also have your Portland, which is composed of 2 zeta and 2 gamma chain. And then you have what we call the hemoglobin H, which is composed mostly of 4 chains of beta, which is considered to be non-functional. Then you also have your Bart's hemoglobin, which is composed mostly of the gamma chain. We see traces at birth, and this is also a non-functional hemoglobin. So most importantly in adults would be the hemoglobin A, which is 95% of the total hemoglobin in adults would be hemoglobin A, and 3% would be the glycosylated hemoglobin, and 2% would be your hemoglobin A2. You have a fetal hemoglobin or hemoglobin F comprises less than 1%. Most of these Gower 1 and 2 Portland are all embryonic hemoglobins. Again, to show you the pluripotential stem cells or the origin of the erythroid and myeloid series, you have to remember that the myeloid series is, or this is a common origin, this is a common stem cell for four cells in the hematopoietic system. You have your granulocytes, which is the precursor, the colony forming unit GEMM, G for granulocytes. So this is the source of the future neutrophils, basophils, and eosinophils. Then you have the erythroid series or the E series. And then you have your M, the monocyte, and then you have the megakaryocyte. We will not be talking about the lymphoid stem cells because they belong to another cell line. So we'll be concentrating here on the myeloid stem cell series. So you have the different blast forming unit to the colony forming unit erythroblast to the proerythroblast to the erythrocytes. So this is, concentrate on this one, the erythrocytic series. So the most primitive precursor of the RBC is a pronormoblast. It's still nucleated. And then it converts into a basophilic normoblast, and then a polychromatic normoblast, and then the orthochromatic normoblast, which is the last of the nucleated red cells, nucleated red cell precursor in the erythroid series. And then you have your polychromatic erythrocytes. The polychromatic erythrocytes, this corresponds to your reticulocytes. And then eventually, your polychromatic erythrocyte is enucleated as well. And then eventually you have your mature erythrocytes. So anemia is defined as the reduction below normal limits of the total circulating RBC resulting in decreased oxygen transport. So signs and symptoms may be generalized. People may present with weakness, malaise, easy fatigability, dyspnea, and malexertion. So it's quite general. You may see this in any of the diseases. On physical examination, you might note for pallor, most especially noted in the palpebral conjunctiva, in the nail beds, in the frenulum of the tongue. Some may present headache, dizziness, angina, murmur. Most of these are related to hypoxemia or decreased delivery of oxygen into the tissue. Oliguria and anuria would set in if there would be blood loss. Brittle nails, koilonychia, these are changes that we see on the nails, can also be seen in certain forms of anemia. Okay, so to your right, or I hope this is your right, so you can see a normal palpebral conjunctiva and a normal frenulum of the tongue. This on your left is a pale palpebral conjunctiva and a pale frenulum. You can also compare, on your right is a hand that is normal, and on the other hand, on the left would be hands with pallor. So these are some of the changes that we see on the nails. You can see brittle nails, you can see koilonychia. So these are some of the normal value. We use this to label a person whether he has anemia or not. For the hemoglobin, it's 12 to 14 grams per deciliter in females and 13 to 16 grams per deciliter in males. For hematocrit, it's 33 to 42% in females and 39 to 48% in males. For the reticulocyte count, it's between 0.5 to 1.5%. And other tools that we use also to diagnose anemia is peripheral blood smear, and also your indices such as your RDW, which ranges from 11.5 to 14.5. RDW measures the size of the red cell or the anisocytosis. And then other indices, you have your MCV, which is a reflection of size. So you have the formula, hematocrit divided by RBC count times 10. So the normal would be ranging from 80 to 94. So a number that is lower than that would be considered microcytic, and a number lower than or higher than 94 is considered macrocytic. MCHC is expressed in grams per deciliter. MCV, by the way, is expressed in, this is a volume, so this is in femtoliters. MCHC is expressed in grams per deciliter, which is a reflection of the color of the red cells. So the formula is hemoglobin divided by hematocrit times 100. So any number that is lower than 32 is considered hypochromic. So any number that is between 32 to 36 is normochromic, and anything that is above 36, we can say it is hyperchromic, and we see this usually in patients with increased reticulocyte count, or those what recovering bone marrow, probably from a blood loss or from anemia as a result of treatment. Then MCH, on the other hand, is expressed in picograms. The normal value is between 25 to 34. It has no unit. So the value is, or the formula is RBC divided by RBC count times 100. Anemia can be classified based on morphology. So if the indices are within normal limits, we call that normocytic, normochromic. If the indices are lower than normal, we call that hypochromic microcytic, and this is common in the following diseases: iron deficiency anemia, thalassemia, and sideroblastic anemia. But there is a mnemonic for you to remember hypochromic microcytic anemia. It goes by the mnemonic TICS: thalassemia, iron deficiency, chronic disease, and sideroblastic anemia. So TICS, T-I-C-S. And then macrocytic anemia, if the indices are, of course, higher than the normal ranges, you see this mostly in what we call macrocytic or megaloblastic anemia, exemplified by cyanocobalamin and folic acid deficiency. Okay, so at the center of the slide or the PowerPoint is a normocytic normochromic anemia, whereas to your right are the hypochromic microcytic anemia. You can see the central pallor is very, very big. It's almost like a very, very thin rim of color around the red cells. And if you would compare the size with the surrounding cells, this is, I think, a basophil. It's smaller, but our internal ruler, as you have been shown in the laboratory, our internal ruler for the use for the size of the red cell would be the nucleus of an average size lymphocyte. Supposed to be this is megaloblastic. Some cells are larger, but there are varying sizes of the cells. So for you to say that the cell is normal in size, decrease in size, or increase in size, is we have to compare it with the nucleus of an average size lymphocyte. So that is why this is what we call the internal ruler when it comes to eyeballing of the size of the red cell on the peripheral blood smears. Let's try to classify anemia according to causes. Number one would be blood loss. Acute blood loss would usually result to normocytic normochromic because the peripheral blood as well as the bone marrow would still be able to compensate. But you would be expecting leukocytosis, an increase in platelet count, as well as reticulocytosis after treatment. Whereas if you have chronic blood loss, it may result to hypochromic microcytic anemia. How about anemia that is resulting from increased rate of destruction, like what we see in hemolytic anemia? It may be intrinsic, or it's an inherent defect of the red cell, like what we see in glucose-6-phosphate deficiency, glucose-6 phosphatase deficiency, sickle cell anemia, pyruvate kinase, spherocytosis, and thalassemia. Or it may be extrinsic because the cause may be coming from outside that would just destroy the red cells. Like if you have parasitic infestations like in malaria, or there could be an antibody that is destroying the red cells, or maybe it's a metal, heavy metal that is initiating the destruction of the red cells, or SLE, because SLE, we know that we produce antibodies against red cells in cases of patients with SLE. And then there's also a category that says impaired red cell production. Like there could be defective synthesis of the DNA, which we see in the megaloblastic anemias, like what we see in B12 and folic acid deficiency, or could be a defective hemoglobin synthesis, like maybe a deficiency in the heme production, like what we see in iron deficiency, or could be a problem in the production of any of the globin chain, which we see in thalassemia, or could be a disturbance in the proliferation of the stem cell, like what we see in aplastic anemia, or there could be a block, or there could be a suppressor to the bone marrow production, as well as anemia of renal failure, because we know that maturation of red cells needs erythropoietin, and part of the erythropoietin molecule comes from the kidney, so that is why in cases of renal failure and even with liver failure, you also have anemia because partly the erythropoietin molecule would come from these organs. What are the characteristics of, let's start with hemolytic anemia. So, meron kang tatlo, meron kang tinatawag, I have these mnemonics H, E, and A. So first is accumulation of the products of hemoglobin catabolism. So heme is converted to hemosiderin, and then this would be incorporated into the what we call the siderocytes. And eventually, hemosiderin may be broken down into bilirubin. That is why in cases of hemolytic anemia, there would be increase in indirect bilirubin. And eventually, this might lead to formation of stones in the gallbladder. Aside from an accumulation of the products of hemoglobin catabolism, there is also increase in erythropoiesis. So this is manifested by a marrow that is very cellular. So there would be increase in normoblasts as well as increase in reticulocyte count. There could also be what we call extramedullary hematopoiesis. So the other organs aside from the bone marrow would also be producing red cells like the liver, the lymph nodes. Another would be premature destruction of RBC, which causes anemia. As a result of the destruction, you release enzymes that are inherent to the red cells. One of those is your lactate dehydrogenase. So, accumulation of the abnormal products of hemoglobin catabolism, increased erythropoiesis, and anemia are the prominent characteristics of a patient or presentation of someone with hemolytic anemia. So what do we see in the specimen? Presence of free hemoglobin. There could be hemoglobin in the blood or hemoglobin in the urine. There would be metalbuminemia and decreased serum haptoglobulin or haptoglobin. And then there could also be hemosiderin in the urine, of course, plus there would be jaundice and anemia. Pallor as well as yellow discoloration of the skin and the sclera. Let's talk about causes of intravascular hemolysis, meaning to say these are the hemolytic destruction that takes place within the blood vessel. It may be a result of mechanical injury, like for example, a patient have artificial heart valves, so upon passing through the prosthetic valve, the red cells could get destroyed, or could be a result of a thrombus formation like what we see in disseminated intravascular coagulation. It may be a result of an antibody like what we see in transfusion mismatch. You may also see this in paroxysmal nocturnal hemoglobinuria, or maybe secondary to an infection like what we see in malaria, or at fourth may be inherent like a membrane defect like in G6PD deficiency, glucose 6-phosphate deficiency. How about extravascular hemolysis? So these are hemolysis that takes place outside of the blood vessels. It may also present with anemia, jaundice, as well as enlargement of the spleen. Because we know the spleen, as what we call it, is the graveyard of old RBCs, or old and as well as destroyed red cells. So this is a normal bone marrow, if you notice. These are your RBC precursors. These are some of the mature granulocytes. If you notice, more or less, they are equal in number, but here, in erythroid hyperplasia, you would see a lot of those nucleated forms of red cells. Here, I could only count around 1, 2, 3, 4, 5. In this slide, I could count 1, 2, 3, 4, 5, 6. Pwedeng too numerous to count. If you compare it with the slide on your left to the slide on your right, you can see the discrepancy between the numbers of nucleated RBCs compared to the numbers of nucleated RBCs on this slide to your right, which shows erythroid hyperplasia. So this is your reticulocyte stain to count for the number of reticulocytes. So this is on right stain, the usual stain that we use for peripheral smear. The reticulocytes would appear to be polychromatic red cells, but you cannot see the fine reticular network You can only see this with supravital stains like your new methylene blue. So those are the reticulocytes rather. Then let's go to hemolytic anemias. One would be hereditary spherocytosis. So in hereditary spherocytosis, there is an inherent membrane defect. There is an abnormality in most of the contractile membrane proteins such as pectin and actin and ankyrin. So why are these important? Because we know that red cells has to change its shape when it passes through blood vessels of lesser caliber, like in the arterioles, in the venules, in the arteries. What happens here is instead of the red cell possessing what we call a discoid shape, it changes in shape and it becomes inflexible when it passes through small capillaries, especially the spleen. And this abnormality or this inability of the red cell to change its shape may lead to hemolysis. So on peripheral smears, the red cell appears to be spheroidal and there is an absence of a central pallor. Main symptomatology, patients may present with splenomegaly as a result of a constant hemolysis, and they may also present with jaundice as a result of increase in production of bilirubin. And in some patients, splenectomy may correct the anemia. Okay, this is just to show you the normal RBC. This is a spherocytic red cell which does not change in shape. That is, it's easily trapped by the splenic macrophages. So this is supposed to be a normal red cell that when it enters very, very small passages, it has to change its shape. So splenic trapping may result to decrease in the glucose, ATP, decrease in pH, and increasing macrophage contact, which favors hemolysis. So this is a normal red cell. It has a normal donut shape or discoid shape. It presents with anemia, jaundice, and splenomegaly. Around 20 to 30% of patients with HS would be asymptomatic, but most would present with chronic hemolysis, which is presented with marked anemia and jaundice, and some people may even need exchange transfusion. Most of the time, these patients have a very stable course, and some of them may go into aplastic crisis if they would encounter a particular virus called parvovirus, and some of them may go into hemolytic crisis if they would encounter a Epstein-Barr virus, or in patients who would end up with infectious mononucleosis. In the laboratory, one of the tests that we can use to differentiate a normal red cell from hereditary spherocytosis is your osmotic fragility test. So the test is used to determine the susceptibility of the red cells to rupture. The shape of the RBC is the main determinant factor of the test. Normally, you can expect the red cells to rupture as the solution of the NSS or the sodium chloride or the NSS solution becomes hypotonic. You do not expect hemolysis in hypertonic solution. You can expect hemolysis only in, this is talking about normal, you can expect hemolysis in a normal RBC with if the solution becomes hypertonic. That is not the case with hereditary spherocytosis. They start hemolyzing even with hypertonic solution, so even with isotonic solution, which is not the case with sickle cell disease. In sickle cell disease, they would hemolyze. They would hemolyze only with hypotonic solutions. In spherocytes, even with hypertonic or even isotonic concentrations of NSS, the red cells would start to hemolyze. Next, let's start with G6PD deficiency. So, glucose 6-phosphate is this is converted to 6-phosphogluconate by the enzyme glucose 6-phosphate dehydrogenase using your NADH and converting it to NADPH. Then this is important since the reaction would generate what we call the antioxidant glutathione. And in the absence of glutathione, the red cells is always subjected to the reactive oxygen metabolites like hydrogen peroxide. So the cells would be normally would normally that will not be hemolyzed as a result of increased exposure or the absence of your antioxidant, the cells are readily susceptible to the reactive oxygen species. So on peripheral blood smear, the red cells appear to be normocytic and normochromic. There will be increase in reticulocytes. There will be formation of Heinz bodies as well as bite cells, as you can see here in the picture. So what would precipitate a hemolytic crisis in a patient with G6PD? Number one is if they are exposed to oxidant drugs like chloramphenicol, the sulfa drugs. Also, if they are exposed to certain kinds of food like fava beans, infection. You have several, not several, but two variants of G6PD. You have the G6PD variant, which has only the mature red cells that would lack the G6PD enzyme, whereas the Mediterranean type, all red cells would lack the enzyme. For the G6PD, the other variant, the non-Mediterranean variant, only the mature red cells would lack the enzyme. So signs and symptoms, they would present with both intra and extravascular hemolysis 2 to 3 days after exposure from the precipitating factor. Most of the time, this is a self-limited hemolysis, and recovery would be the manifestation of recovery would be an increase in the reticulocyte count. They would only present with mild extravascular hemolysis and no other symptoms of chronic hemolysis. Next, we have sickle cell anemia. This is one disease wherein it's a result of an amino acid substitution in the hemoglobin chain. So there is a substitution of glutamine for valine at the 6th position of the beta chain of the hemoglobin. So in the presence of deoxygenation, the hemoglobin S will aggregate and polymerize. And its molecular structure would lead to distortion and sickling of the red cell. And this sickling of the red cell would result to chronic hemolysis in the spleen and would also result to a small vessel occlusion, leading to ischemia. So this is just to show you what happens to the sickle red cells. They could aggregate and cause some form of thrombosis and obstruct smaller vessels. If I'm not mistaken, this is an example of a spleen that has been, I'm not sure if what organ is this. This is just to show you an organ that has been affected by sickling, and you can see there are a lot of thrombosis. So this is how the spleen would look like in sickle cell disease. This is on scanner view. This is in lower power view. So a lot of red cells have been trapped within the spleen. So this is just a comparison between sickle cell trait and sickle cell anemia. So sickle cell anemia, it's you have a homozygous individual. Sickle cell trait, you have a heterozygous individual. Percent of hemoglobin S, mas marami pag sickle cell compared to sickle cell trait when you only have 20 to 40% and the rest are your adult hemoglobin. Symptom would be plugging of cap and pain and infarction in the different organs. So ito yung pinapakita ko kanina. Here. In sickle cell trait, you will not see symptom unless exposed continuously to hypoxemia or decreased oxygen. So mostly spleen are large in patients with sickle cell anemia. In younger patients or smaller adults, it may lead to autosplenectomy, wherein the spleen would be rendered non-functional as a result of a frequent infarction. In sickle cell trait, the spleen is usually normal. In the peripheral smear in sickle cell anemia, you would see normocytic, normochromic anemia. You may see, of course, sickled red cells. You may see normoblasts. You may see Howell-Jolly bodies. Whereas for sickle cell trait, it's normal. Hemoglobin identification. You may see single large bands of hemoglobin S, and in sickle cell trait, you only see a small band of hemoglobin S. I would show you a picture of hemoglobin electrophoresis later. Then other lab abnormalities, as I have mentioned, sickle cell disease, you have decreased osmotic fragility and decreased ESR. You don't see that in sickle cell trait. How about life expectancy or prognosis? Usually sickle cell trait, sorry, medyo maliit yung screen, so para makita nyo, let's end the show. Muna. Okay, the part that you can see is just the lifespan. Usually it's fatal for sickle cell anemia, and it is usually, you would expect a normal life expectancy in patients with sickle cell trait. So this is your hemoglobin or liquid chromatography. This is in sickle cell trait and this is in sickle cell anemia. Take note that in sickle cell anemia, you see very minimal hemoglobin A, whereas in sickle cell trait, as I have mentioned, almost 60 to 80% of the cells in sickle cell trait are or would be made up of adult hemoglobin, and around 20 to 40% would be made up of sickle cells or hemoglobin S, which is the contrast in contrast with sickle cell anemia, where you see very minimal hemoglobin A and mostly hemoglobin S. Okay, so what are the factors that would affect sickling? Number one would be the amount and interaction of the hemoglobin S. So if you have a lot of hemoglobin S, then you would see that there would be sickling. Whereas if you see in what we see in sickle cell trait, since you have hemoglobin A, then it will not present, or it will prevent sickling. Another would be if it interacts with hemoglobin C, there would be polymerization of the hemoglobin S, and the polymerization would also contribute to sickling. What else? Increase in MCHC as well as intracellular dehydration also favor sickling, as well as a decrease in pH. An acidotic pH would also contribute to sickling. Another is the length of exposure to decreased oxygen. Like what we see, if there would be an increase in transit time. What do we mean by increase in transit time? If there would be increase in travel of the red cells across the microvasculature, like what happens in the bone marrow and the spleen, if there is an increase in transit time, there is an increased exposure to decreased oxygen. So this travel or increase in transit time through the microvasculature would also increase the chances of sickling. Infection as well would also increase the chance of sickling. So what would be the consequences of sickling? One is infarction, which would result to capillary stasis and thrombosis. In the spleen, it may lead to autosplenectomy. Parang tinanggal yung spleen as a result of massive infarction. It may also predispose the patient to infection with encapsulated organism, like salmonella is a very common opportunistic infection in patients with sickle cell disease. Then what are the other evidences of chronic hemolysis? Increased red cell destruction may lead to anemia, increased bilirubin, in particular your indirect bilirubin. There could also be increased hemosiderin deposition in the tissue. It may also lead to iron overload, so para siyang hemochromatosis. And then increased erythropoiesis may lead to extramedullary hematopoiesis. So as a result of a hyperactive bone marrow, it may result into what we call a crow haircut appearance of the skull bones on X-ray. So this is a result of a hyperplastic bone marrow because the bone marrow is trying to compensate for the destruction of the red cells. There would also be increase in reticulocytosis as well as normoblasts on the peripheral smear. So what are the critical episodes that can complicate sickle cell anemia? One is what we call your vaso-occlusive crisis, which may result in multiple simultaneous painful thrombosis in a lot of organs. Another would be a plastic crisis where there is a failure of the bone marrow to increase RBC production in spite of the presence of overwhelming anemia. Another is what we call the sequestration crisis, which could result to massive destruction of red cells passing through the spleen. And in that case, the sudden splenomegaly may lead to hypovolemia and shock. Now we go to the thalassemias. These are defective. These are examples of anemias as a result of a defective globin synthesis. So classification in beta thalassemia, so as the term would imply, you have a defective beta globin chain. So kapag ka minor, you have a heterozygous. Heterozygous, isa lang ang nagkikarry ng abnormality. Intermedia, pwedeng kagaya din ng minor, isa heterozygous or could be a mild homozygous. Pag thalassemia major, both beta chains are abnormal. In alpha thalassemia, of course, you have a defective alpha globin chain. So a silent carrier of the trait would possess no symptom at all. If you have the alpha thalassemia trait, it may present with no symptom, maybe just mild anemia. But in cases wherein you have no alpha chains at all, yung hemoglobin H, where you see 4 beta chains in adults, or your hydrops fetalis, wherein you don't have any alpha or beta chain, but you have 4 gamma chains. So this is a combination of a decrease in globin synthesis, so it may result to hypochromic microcytic anemia, and then aggregation and precipitation of unpaired hemoglobin. The abnormal erythropoiesis may lead to the destruction of young RBC, and then it may also present with RBC with inclusions that is easily destroyed by the spleen. So the result of early cell death with result to severe anemia, and constantly the patient may need transfusion, and as a result of transfusion, the patient may end up with deposition or iron overload in hemosiderosis, which could deposit in organs like the liver, the pancreas, and the heart. Again, as a result of massive erythroid hyperplasia, there could be expansion of the red marrow, and again, it may result to what we call the crow haircut appearance on skull X-ray, as well as facial alteration, enlargement of the face with a small jaw. Patient may also present with hemochromatosis or hemosiderosis. There will be massive enlargement of the spleen as a result of increased trapping of the abnormal of the red cells with abnormal globin chain. As a result of destruction, you can also expect jaundice or increase in bilirubin. So this is how a section from a skull bone from a patient with erythroid hyperplasia would look like. This is your crow haircut appearance on a skull X-ray. This is the result of the facial deformity that what we see in thalassemia. So how do we diagnose thalassemia in the laboratory? Of course, one would be hemoglobin electrophoresis. When we talk about beta thalassemia major, you would see that there is no hemoglobin A at all, and there would be marked increase in hemoglobin F as well as hemoglobin A2. In beta thalassemia minor, you may have decrease in hemoglobin A and a slight increase in hemoglobin A2. In alpha thalassemia, you could either have hemoglobin H or Bart's hemoglobin. On peripheral smear, again, it appears to be hypochromic microcytic anemia. You may also see target cells, basophilic stipplings. You may also see evidences of bone marrow hyperplasia in the red cells as well as your peripheral smears. You see a lot of reticulocytes and normoblasts. You would also have iron overload. There would be marked increase in siderocytes and sideroblasts, eventually ending up in iron overload and hemochromatosis. Most of the time, they would die from overloading of the iron into the heart. So what do we see in thalassemia? One would be the presence of basophilic stipplings. Another would be you could see a lot of nucleated red cells and some of your target cell or your Mexican hat cell. Next, we have your paroxysmal nocturnal hemoglobinuria. It is called as such because the hemolysis would happen at night. That is why it's called paroxysmal nocturnal hemoglobinuria. So the chronic intravascular hemolysis would happen at night. So what is the abnormality? You have an abnormality in what we call the PIGA gene. And in the PIGA gene, there would be a deficiency of a stem cell protein, CD59, which is supposed to be a lysis inhibitor, and CD55 and the C8 protein. So that is why in the absence or an abnormality of your PIGA gene, the red cells are very susceptible to lysis by the complement. So most of the time, since I have mentioned that, it presents with intravascular hemolysis. It may have mild hemoglobinuria as well as iron deficiency anemia. Most of the time, the cause of death is episodic venous thrombosis, and patients with PNH have a high risk of developing acute myelocytic leukemia. Then you have what we call immune hemolytic anemia. So the hemolysis is not secondary to the abnormality in the globin chain, not as a result of a membrane defect like what we see in spherocytosis and G6PD, but this is secondary to the appearance or secondary to an antibody that is directed against the red cells. So what do we use to diagnose this type of anemia? There has to be a positive Coombs test. So it may be classified either into warm antibody or warm agglutinin, cold agglutinin, or a cold hemolysin. If you talk about warm antibody immune hemolytic anemia, we are talking about an immunoglobulin G that is active at 37 degrees. It does not fix the complement, but the IgG-coated RBC would bind readily to the monocytes, and they are easily trapped by the splenic macrophages. Most of the time, warm body immune hemolytic anemia are idiopathic. Secondary causes could be secondary to drugs, maybe as a result of lymphomas, leukemias, or autoimmune disorders like what we see in SLE. For your cold agglutinin immune hemolytic anemia, this time it's an IgM that binds to RBC at 0 to 4 degrees, which activates the complement at a slightly higher temperature, but it will dissociate at 30 degrees. Most common cause of the presence or production of cold agglutinins would be in cases of Mycoplasma pneumonia infection and infectious mononucleosis infections. Okay, now we have your cold hemolysin immune hemolytic anemia. This is your paroxysmal cold hemoglobinuria. The IgG antibody binds to the red cells and complement usually at low temperature. And activation and hemolysis would start at the temperature starts to increase. This is characterized by massive intravascular hemolysis following exposure to cold. So please take note that activation or a binding of RBC to the complement starts at low temperature, but activation and hemolysis starts as the temperature would start to rise. Again, common causes may also be seen in Mycoplasma pneumonia infection, other viral infection also like measles, mumps. When it comes to SARS-CoV-2, we have not yet documented the presence of cold hemolysins. Then we'll have what we call the microangiopathic hemolytic anemia. So this is hemolysis resulting from trauma to red cells from narrowing or obstruction in the smaller blood vessels like what we see in DIC, in TTP or thrombotic thrombocytopenic purpura. We also see this in SLE, in malignant hypertension, like what we see in cases of like pheochromocytoma, also in patients with prosthetic or mechanical or artificial valves. Then let's talk about anemia due to decrease in production. One of which is megaloblastic anemia, and megaloblastic anemia is a result of B12 and folic acid deficiency. So these two substances are needed for nuclear maturation and division. That is why, in the absence of this or a decrease in the B12 and folic acid, the nucleus of the RBC remains immature and abnormally large. So this is how the process would take place. In the mouth, B12 is broken down by the enzyme pepsin, and then it is transported by the salivary protein. In the stomach, it is cleaved by the pancreatic enzyme, B12 plus intrinsic factor, and absorption would take place in the ileum. So these are some of the B12 pathways. So in the absence of your tetrahydrofolate, there would be in the absence, there would be no conversion or remethylation into methionine. On the other hand naman, in the presence of methylmalonic acid, this is converted to succinyl coenzyme A. And this is your tetrahydrofolate. So in the absence of this, there would be no formation. There would the tetrahydrofolate and B12 is a cofactor of your enzyme methionine synthesis. So in the absence of this, there would be accumulation of some of these substances which could be toxic to certain organs in the body, like the brain. Let's talk about differentiate the causes of megaloblastic anemia. In B12, you see this mostly in a vegetarian diet because B12 are mostly seen in meat, in particular red meat. Folic acid deficiency are often seen in alcoholics. B12 deficiency is secondary to impaired absorption, like what happens in certain malabsorption syndrome if you have colitis, gastrectomy, or intestinal resection, or maybe what we call gastrointestinal lymphoma. It may also be secondary to a fish tapeworm, yung fish tapeworm, yung Dipilobothrium latum. Whereas with folic acid deficiency, you see this in people who are taking folic acid antagonists like methotrexate. Also, in certain physiologic conditions where there is increased requirement, like what happens in pregnancy, thyrotoxicosis, as well as in chronic hemolysis. And there could also be a result of increasing losses if a patient is undergoing chronic dialysis. So in the peripheral smear, it may appear to be megaloblastic anemia. So you see macrocytic hyperchromic red cells, and you can even see large nucleated RBC on the peripheral smear. We call them your megaloblasts. And then you also have leukopenia with hypersegmented neutrophils, or your macropolis. You are seeing a neutrophil with more than 5 lobes of the nucleus. There could also be, take note, thrombocytopenia. Since this is megaloblastic, the RBC indices are considered to be increased, like MCV and a high normal MCHC. Reticulocyte count is usually decreased. Striking reticulocytosis is seen 5 days after administration or giving of vitamin B12 and folic acid. What else? You may see bone marrow hyperplasia. The bone marrow becomes hypercellular. That is why the erythroid-myeloid ratio almost becomes equal. The normal erythroid-myeloid ratio is you have more myeloid series because the neutrophils, the granulocytes, the monocytes, and megakaryocytes have a shorter lifespan compared to the erythroid, the cells in the erythroid series. That is why you have more myeloid than erythroid, the normal erythroid-myeloid ratio. So you have more myeloid than erythroid. You may also see megaloblasts, and you can see all stages of the myeloid development are large. And you would see asynchronism or dissociation in the nucleus and cytoplasm of the red cells. Of course, you may have decrease in vitamin B12 and decrease in homocysteine and methylmalonic acid because they are not converted to homocysteine and methylmalonic acid as a result of deficiency of B12 as well as your tetrahydrofolate or your folic acid. So you can see you have a hyperchromatic, large red cells, and you have a increased segmentation of the neutrophils. Tawag natin dyan macropolis. 1, 2, 3, 4, 5. So you have more than 5 segments or lobations of the neutrophils in this slide. This is a very exaggerated hypersegmentation of the neutrophils. You can also see there is a megaloblast with nucleocytoplasmic dissociation. See, the nucleus are large because, as I mentioned, there is a maturational arrest in the development of the nucleus, so they would appear to be abnormally large as a result of a deficiency in B12 and B and folic acid. These are some of the complications in the brain. It may result to demyelination of the dorsal and lateral tracts in the spinal cord, not the brain. Sorry for that. Then we have what we call pernicious anemia. This is a type of megaloblastic anemia caused by autoimmune destruction of the gastric mucosa as a result of loss of the parietal cells, but consequently there would be a decrease in or loss of the intrinsic factor. So what causes this type of anemia? One, 70% may be a result of autoantibody to intrinsic factor. The type 1 would usually blocks the attachment of B12 to the intrinsic factor, whereas type 2 blocks the B12 intrinsic factor complex with the receptors in the ileum. Another would be autoantibody to the gastric parietal cells. And they are usually directed against the parietal cells. We know that the parietal cells secretes or produces the gastric intrinsic factor. And these antibodies that are directed to the gastric parietal cells may lead to atrophic gastritis and eventually atrophy of the stomach. Since there is atrophy of the stomach, it may present with achloridsia or decrease in acid production in the stomach with positive serum antibody production. So we may see this as atrophic glossitis or an atrophy of the tongue. You can see that the tongue is usually smooth instead of seeing those taste buds and papilla in the tongue. And also atrophy of the stomach, which could lead to increased risk for gastric carcinoma formation. So this is normal. This is from a patient with gastric atrophy. You can see that the tongue is very smooth. And at the bottom, you can see that there are normal folds in the stomach, and on top, you can see a stomach with atrophy of the gastric mucosa. Now we go into iron deficiency anemia. So this is the most common nutritional disorder that we encounter. So causes would be probably low dietary intake, poor absorption, excessive demand like what we see in pregnancy and children, as well as from chronic blood loss. So intestinal absorption, you have your plasma transferrin and iron. It could go into the liver, it may go into the myeloid erythroid precursor, then you have the circulating erythrocytes, and then the mononuclear phagocyte stores will again put it into the plasma transferrin iron, which could be either be lost in the skin, the genitourinary tract, the endometrium, and the normal shedding or the normal blood loss is around 1 to 2 milligrams per day. This is the loss of iron. This is the normal iron loss that is expected on a daily basis. So on PBS, as what I've earlier mentioned, it may present with hypochromic microcytic anemia. The retic may be normal, or there could also be normoblast. The platelets is normal, as well as the WBC. In the bone marrow, you would see decreased sideroblasts. In the iron indices, since there is a very low iron store as a result of increase probably in losses or increase in intake, there will be decrease in serum iron and serum ferritin. But there would be increase in total iron binding capacity because the receptors are hungry for iron, so there would be increase in TIBC. There would be elevated RDW since the cell would appear to be smaller, so there would be increase in distance between the individual RBCs. So treatment, you would expect reticulocytosis within 3 to 5 days of treatment, actually iron treatment or blood transfusion. Signs and symptoms, some of them may present with, this is with chronic iron deficiency anemia. Some of them may present with nail abnormalities like koilonychia. Some of them may present with baldness. In severe cases, it may present with pica. This is craving or eating, craving for unusual items to eat like soil, crayons. It may also present with atrophic gastritis and glossitis. And there is a particular syndrome where you can see esophageal webs, atrophic tongue, and iron deficiency anemia. We call that your Plummer-Vinson syndrome. And this is just to show you the staining. If there is decreased iron stores in the bone marrow, you can see that there are blue discoloration, and here you have very minimal Prussian blue staining. So this is what we see in patients with severe iron deficiency anemia. And let's talk about anemia of chronic disease. The problem here is there would be an impairment in iron absorption as a result of increase in hepcidin. There will be a reduction of the erythroid precursor and impaired iron utilization. So we see this in chronic microbial infection, chronic infection, chronic immune disorders, as well as in certain forms of cancers. So this is to compare the chronic disease, iron deficiency, anemia, and thalassemia when it comes to serum iron. So chronic disease and iron deficiency anemia, you expect a decrease in serum iron, whereas it's increased in thalassemia. Serum ferritin is increased in chronic disease, decreased in iron deficiency anemia, increased in thalassemia. Whereas total iron binding capacity is decreased in thalassemia and chronic disease, whereas it is increased in iron deficiency anemia. And you can see the morphology. In chronic disease, it could be normocytic or hypochromic microcytic, but it's a hypochromic microcytic for both iron deficiency and thalassemia. Now let's talk about anemias of marrow failure. First, you have aplastic anemia. So this is marrow failure due to suppression of hematopoiesis. So the bone marrow may appear hypocellular with no response to treatment. The peripheral blood smear, it would appear to be pancytopenic, so meaning to say all cell lines are affected. The retic count is also decreased, so most of the time treatment is bone marrow transplantation or the use of immunosuppressive therapy. Let's talk about causes of aplastic anemia. You have one hereditary form where you have your Fanconi's anemia. You have your idiopathic, where you have a stem cell defect, and most of the time aplastic anemia may be acquired. It may be a idiosyncratic reaction to certain drugs like chloramphenicol, carbamazepine. Chloramphenicol is an antibiotic. Carbamazepine and phenytoin are anticonvulsants. Or reactions to chemicals like benzene compounds, alkylating agents like what we see in insecticides, or could be secondary to infections with CMV, parvovirus, and hepatitis, as well as Epstein-Barr viruses. So you can see there is almost an equal number of the marrow and the fat here. This is naman a bone marrow that is hypocellular. This is a normocellular bone marrow. This is a hypocellular bone marrow where you can see there is more fat than marrow cells. This is a hypercellular marrow where you don't even see any fat at all. So this is normal. Oops. This is normal. This is hypocellular. This is hypercellular. So this is the characteristic bone marrow that you would see in the patients with aplastic anemia. Then other causes of anemia, you may have what we call myelophthisic anemia. This is when the bone marrow has been replaced by a space-occupying lesion. Most of the time, this could be a result of metastatic carcinoma, multiple myeloma. So on peripheral blood smear, It may appear to be pancytopenic, and you have teardrop-shaped red cells, what we call the lacrimocytes. You also see this in chronic renal failure, diffuse liver disease, some forms of cancer, as well as in hypothyroidism. If you notice, these are the normal marrow cells. You have fat, you have marrow cells, and you have a foreigner, a mass here that replaces the marrow tissues. On higher power view, this is how the tumor would look like. So this is a myeloproteic marrow wherein the bone marrow has been invaded by a metastatic cancer cells. Again, comparison of anemia by red cell indices. So you can just read it on your own. Pagka thalassemia tsaka iron deficiency, all of it are decreased. Let's talk about pernicious anemia. Diba ito yung mga megaloblastic anemia. These are your microcytic anemia. These are your normocytic anemia. This is our macrocytic anemia. If you notice, all of the indices are increased. These are your normocytic anemia. Again, these are your microcytic anemia. Chronic inflammation and chronic disease could either be normo or microhypoanemia. This is the opposite of what we were talking about. We talked about anemia in the first portion of the lecture. This time, we'll talk about the opposite, which is an increase in red cell mass. It may be relative as a result of dehydration. It may be absolute, like what we see in primary polycythemia vera, or secondary polycythemia vera, wherein the increased erythropoietin secretion is just compensatory, maybe as a result of chronic hypoxemia or a result of a paraneoplastic syndrome. Another would be stress polycythemia, or what we call the Grace-Bach syndrome. Again, you have increased marrow production of the myeloid precursor. Pathogenesis, there could be mutation of the tyrosine kinase JAK2 erythropoietin receptors. So on laboratory diagnosis, on peripheral blood, you have panmyelosis, meaning to say all of the myeloid series are affected, from the granulocytes to the red cells to the monocytes to the platelets. So RBC may number into more than 6 million. WBC may range from 12 to 50,000. Platelets more than 500,000, and hematocrit that is more than 60%. So most of the time, these are common in males, middle age to elderly males. So this is just to show you what happens here. You have the growth factor, which could increase all the possible pathways, and then transcription factor activation, which could lead to increased stimulation of the myeloid series, or could also be a result of the cytokines. So patients may appear to be plethoric, yung mapulang-mapula. They may also appear cyanotic because the blood is very, very thick. Some may experience or complain of pruritus. Others may complain of peptic ulcer. Others may complain of headache, dizziness, and hypertension. Again, these are all results of hypoxemia because there is very sluggish flow of the blood. So complication, patients may have bleeding, or it's extremes. They may bleed or would have thrombotic episodes. Pwede silang nagbe-bleed, pwede din silang nag-perform ng abnormal thrombosis. As a result, again, of increased red cell destruction, they may produce or they may end up with hyperuricemia. So prognosis with regular phlebotomy, it may extend the life. If myelofibrosis would set in, there is 20% na lang yung survival rate in 10 years. And then 2% of them might end up with acute myelocytic leukemia. Okay. Maybe we can talk about the bleeding disorders and just talk about transfusion, but that is also very short for the for the part 2 of the lecture. Maybe we can talk about a little bit about the bleeding disorders. Maybe we can extend up to the platelets if you don't mind. So let's talk about the causes of bleeding disorders. If we talk about disorders involving the blood vessel and the platelet, this is what we call the primary bleeding disorder, because when the clotting factors would enter the picture, this is where your secondary bleeding disorders. So if we talk about blood vessel disorders or blood vessel, if the cause of the bleeding disorder is secondary to a blood vessel, all parameters should be normal. So what are these parameters? Platelet count, blood bleeding time, clotting time, your prothrombin time, and your activated partial thromboplastin time. So when I talk about platelet number, platelet abnormality in the platelet, if you talk about platelet abnormality, quantitative platelet abnormality, of course, you would expect a decrease in the platelet count. We call that thrombocytopenia. There would be increase in the bleeding time. If you talk about platelet function or qualitative platelet defect, there would be normal platelet count and increase in bleeding time. If we talk about clotting factor abnormalities, there could be prolongation of the clotting time, and then if we are talking about deficiency in the extrinsic factor, the lab parameter would be your prothrombin time. Intrinsic factor, the lab parameter that we use is your APTT or activated partial thromboplastin time. Let's talk about vessel wall abnormalities. So they would produce small hemorrhages in the skin or the mucous membranes. These are what we call the non-thrombocytopenic purpura, and we presume that all bleeding parameters are normal. So what causes vessel wall abnormality? Or what are the causes of bleeding secondary to vessel wall abnormality? It may be secondary to infection, like what we see in meningococcemia, in measles, in infective endocarditis. Maybe we can also see this in vitamin C deficiency or scurvy, or a connective tissue disease or Ehlers-Danlos disease. It may also be secondary to intake of certain drugs like penicillin, the sulfas, or could be secondary to henoch-Schönlein purpura, or a hereditary condition, what we call your hemorrhagic telangiectasia syndrome or Osterweber-Rendu syndrome. Next, we'll talk about quantitative platelet abnormality or a decrease in the platelet number. So the normal platelet count is between 150 to 450,000. So any number that is less than 150,000 is considered to be thrombocytopenic or thrombocytopenia. If your platelet count is as low as 20,000, you might have or you can suffer from spontaneous bleeding. If it's between 20 to 50,000, patients would bleed secondary to trauma, like bumping into hard objects. So this is the time that you would see this. Characteristics of the bleeding when it comes to platelet, usually it's superficial. You can see petechial hemorrhages or those pinpoint hemorrhages in the skin as well as in the mucous membrane. Patients would also easily bruise. Some of them may present with bleeding in the GI and genitourinary tract and could present as melena, hematuria, or increased menstrual flow. Our biggest fear here is the threat of intracranial bleeding if your platelet count would be very, very low. So what causes thrombocytopenia? It may be secondary to bone marrow disease like what you see in aplastic anemia or myelocytic anemia. It may be secondary to ineffective megakaryopoiesis like what we see in B12 deficiency. It may be a result of destruction of the platelets like what we see in infection, what we see in certain infections. Dengue hemorrhagic fever is one of them. Could be immune-mediated, like what we see in certain autoimmune diseases like SLE. It may be secondary to drugs. It may be a result of massive transfusion or sequestration. Then what we have to call your heparin-induced thrombocytopenia. You have your type 1. It could appear 1 to 2 days after treatment. There is no clinical significance for your HIT1, you have to continue treatment. So these are in people who are constantly being given an anticoagulant called heparin. And then type 2, it occurs 4 to 14 days after treatment. You have the heparin or the heat type 2. This is usually life-threatening, so we need to stop heparin treatment. So let's start with abnormalities in the numbers of platelet. One would be what we call your idiopathic thrombocytopenic purpura. So this is an autoimmune disorder when you have antibodies directed against the platelets. So the bone marrow may appear normal or there could be megakaryocytosis. In acute ITP, it is usually self-limited, more often seen in children and usually follows a viral infection. Whereas chronic ITP may be seen in adults, especially in reproductive females or in females who are in their active reproductive life, and more often accompanies autoimmune disorders or some lymphoproliferative disorders. Then you have your thrombotic thrombocytopenic purpura. This is characterized by hemolytic anemia involving the smaller blood vessels. There is usually fever, transient neurologic deficits, and renal failure in females in the 4th decade of life. So in contrast to dito, di ba? Acute is in children following viral infection. This is seen in adults. Chronic ITP in reproductive females with autoimmune disorders. Here, we present with microangiopathic hemolytic anemia, fever, transient neurologic deficits, renal failure most often seen in females in the 4th decade of life. So you can see widespread hyaline microthrombi para siyang BIC. Pathogenesis is due to excessive activation of the platelet due to a deficiency in the enzyme called Adams-13. Treatment is plasma exchange. It has to be differentiated with hemolytic uremic syndrome. So this is just to show you that the deficiency on Adams-13 could lead to this is where the deficiency would lie in thrombotic thrombocytopenic purpura. In the absence of Adams-13, there would be excessive activation of the platelets. Hemolytic uremic syndrome, as I've mentioned, they present with the same manifestation as thrombotic thrombocytopenic purpura without the neurologic manifestation. Without the neurologic manifestation, but the renal manifestation is prominent. Uremic, hemolytic, uremic, so there is uremia. So you have signs and symptoms of hemolysis that are present. Again, it also is the same or similar to TTP where you have widespread hyaline microthrombi. Again, this time the excessive activation of platelets is by a bacterial toxin secondary to E. coli infection. I think we can end here and we'll continue next time. Platelet function and then also with transfusion reactions. An advanced copy of the lecture has been posted in Moodle if you would like to download it.